Hi everyone, my name is Ryan. In this presentation, I'm going to explore panic disorder through the lens of emotion and motivation, and then connect that directly to evidence-based intervention choices. I'll cover what's happening physiologically during panic, the role of the sympathetic and parasympathetic nervous systems, the key neurotransmitters and hormones involved, and the fight, flight, freeze response. From there, I'll discuss potential causes, common comorbidities, and then walk through treatments, both psychotherapy and medication, before ending with how recommendations may shift for different populations and cultural contexts. To set the frame, I'm using a guiding idea. Panic disorder can be understood as a problem of threat learning plus interoception, where the person becomes highly tuned to internal sensations and interprets them as dangerous, and then the disorder is maintained by avoidance, motivation, and negative reinforcement. In other words, the immediate goal becomes make this feeling stop, and the actions that reduce fear in the short term, like escape, avoidance, or safety behaviors, get reinforced because they provide relief. Today I'll do 5 things. First, I'll describe the physiology of panic, including autonomic activation and respiratory sensitivity. Second, I'll clarify how the sympathetic and parasympathetic systems contribute to the experience. Third, I'll summarize neurotransmitters and hormones associated with panic and threat responding. Fourth, I'll review causes, comorbidities, and differential considerations. And fifth, I'll apply these emotion and motivation concepts to treatment planning, including how approaches may change across populations and cultures. So let's ground this in the DSM-5-TR definition. Panic disorder involves recurrent unexpected attacks, followed by persistent concern about more attacks or what they might mean, and then maladaptive behavior change, which often shows up as avoidance and safety behaviors. From an emotion and motivation perspective, panic is more than anxiety. Fear is an action tendency. It pushes the body and mind toward immediate, urgent responding. Attention narrows especially toward internal cues like heart rate, breathing, dizziness, or derealization. Then motivation shifts quickly. The person's dominant goal becomes escape or control because that goal promises immediate relief. That sets up the maintenance cycle. A bodily sensation appears, it's interpreted catastrophically, like I'm dying or I'm going to faint. Fear surges, the person avoids or uses safety behaviors, and then they feel relief. The key point is that the relief is short term, but it powerfully reinforces the avoidance, making future panic more likely. Now let's talk physiology. Panic attacks involve rapid activation of body systems, palpitations, sweating, trembling, chest tightness, shortness of breath, nausea, dizziness. What matters clinically is not only that these sensations occur, but that they become threat cues. In panic disorder, the person often develops an interoceptive threat appraisal, meaning the body sensations are interpreted as signs of immediate danger. Over time, internal sensations can become conditioned triggers. That's sometimes called interoceptive conditioning, where the sensation itself becomes the quote-unquote alarm. A second piece is respiratory and chemosensory sensitivity. There are models like the false suffocation alarm theory, suggesting some individuals are especially sensitive to CO2 or respiratory changes. CO2 challenge studies can reliably evoke panic-like symptoms in vulnerable individuals, and hyperventilation can amplify sensations like tingling, lightheadedness, or chest tightness, sensations that then feed catastrophic interpretations. Finally, there's neurocircuitry. The amygdala-centered threat circuitry contributes to rapid alarm activation. The insula plays a major role in interoceptive awareness, basically assigning meaning to body signals. Prefrontal regions support regulation and reappraisal, and in panic disorder, that regulation often gets outpaced by the speed of the alarm response. Here's a simple way to understand the autonomic nervous system in panic. The sympathetic nervous system is the mobilizer, and the parasympathetic nervous system, especially vagal activity, is the recovery system or brake. When the sympathetic system activates, heart rate rises, respiration increases, sweating increases, and the body redirects energy toward action. In panic disorder, these normal mobilization sensations become feared. People can develop what's sometimes described as fear of fear, because they're afraid of the sensations themselves. The parasympathetic system helps the body downshift when threat is resolved. Clinically, we often talk about vagal flexibility or heart rate variability as one marker of how efficiently someone can return to baseline after activation. Lower flexibility has been linked with anxiety disorders in meta-analytic work. So one clinical translation is panic feels like the sympathetic accelerator is flooring it and the parasympathetic brake isn't engaging fast enough. Psychoeducation helps people reframe symptoms as an alarm system, not proof of catastrophe. Treatments then targets two core problems. First, catastrophic appraisal, and second, retraining the system through exposure and skills so recovery becomes more flexible and less frightening. At the neurochemical level, it helps to think in systems rather than single panic chemicals. One key system is norepinephrine, which drives arousal and vigilance and can amplify alarm sensations. Another is serotonin, which modulates threat processing and is why SSRIs and SNRIs are commonly used. GABA is the primary inhibitory system, and that connects to why benzodiazepines can rapidly reduce symptoms because they increase inhibitory tone, though they come with significant risks. Glutamate is central to excitatory learning and fear circuitry, so it matters for how threat learning consolidates. On the hormonal side, the HPA axis and cortisol coordinate stress responding, and dysregulation may increase vulnerability for some people. Adrenaline and noradrenaline release peripherally contribute to the physical sensations, so racing heart, shakiness, sweating, that people often interpret catastrophically. Clinically, this matters because medications primarily target neurochemical modulation, while psychotherapy targets threat learning and meaning making, basically changing what sensations predict and what they mean. The fight, flight, freeze response is a helpful motivational framework because it highlights panic as a defensive survival system that becomes miscalibrated, often triggered by internal cues rather than external danger. Fight can show up as urgency, anger, or frantic attempts to fix the problem now, such as excessive checking, reassurance seeking, or pushing for medical tests repeatedly. Flight is often the most obvious escape, motivation, avoiding places associated with panic, and over time this can develop into agoraphobic patterns. Freeze can show up as immobility, feeling stuck, derealization, depersonalization, or shut down like numbness. When I think clinically, this is useful because I'm not just targeting fear, I'm targeting the motivational programs that fear activates, like escape, control, and safety seeking, and I'm helping the client build new responses that reduce avoidance and increase flexibility. Panic disorder is best understood through a biopsychosocial model. Biologically, there may be genetic vulnerability, neurochemical sensitivity, and in some people, respiratory or chemosensory sensitivity, like heightened reactivity to carbon dioxide shifts or breathlessness cues. Cognitively, a central mechanism is catastrophic misinterpretation of bodily sensation, for example, interpreting a racing heart as a heart attack. Another major factor is anxiety sensitivity, meaning fear of arousal sensations themselves. Attentional biases also matter. People may selectively scan for internal threat cues, which increases detection of normal bodily fluctuations. Learning and conditioning are huge. Interoceptive conditioning means sensations become triggers. Contextual conditioning means places like stores, highways, or classrooms become linked with panic and start triggering anticipatory anxiety. Then avoidance learning and safety behaviors get reinforced through relief, which is negative reinforcement again. Finally, stress and development matter. Chronic stress can bias threat detection, and early adversity may shape emotion regulation systems. Repeated panic attacks consolidate the avoidance goal, and the person's life becomes organized around preventing panic rather than pursuing valued activities. Panic disorder rarely exists in isolation, though. Common comorbidities include agoraphobia, major depressive disorder, generalized anxiety disorder, social anxiety disorder, PTSD and trauma-related disorders, and substance abuse disorders. Substance abuse is especially important because substances can function like safety behaviors used to blunt sensations, avoid fear, or manage sleep, yet they often worsen panic over time or complicate withdrawal. Differential diagnosis matters because panic-like symptoms can be caused or exacerbated by medical conditions such as thyroid issues, cardiac arrhythmias, asthma, or other respiratory conditions, and also by substances or medications like high caffeine intake, stimulant effects, or withdrawal states. Comorbidity changes treatment planning too. It often predicts higher impairment and slower recovery. It also means we might expand targets beyond the panic cycle, addressing trauma triggers, depressive withdrawal, or substance use patterns. And we need coordination with medical providers for rule outs and medication monitoring when indicated. In clinical psychology, the strongest evidence base is for CBT for panic disorder, especially with an exposure-based approach. The core components include psychoeducation, explaining panic as an alarm system, cognitive restructuring to test catastrophic predictions, interoceptive exposure to safely evoke feared sensations, and in vivo exposure to reduce avoidance and agoraphobia in real life contexts. A critical piece is identifying and dropping safety behaviors and then building relapse prevention plans so gains generalize over time. From an emotion and motivational lens, CBT works because it changes learning. Exposure builds new associations, sensations do not equal catastrophe, and anxiety is tolerable. Avoidance motivation decreases as self-efficacy increases too. The client shifts from I must escape to I can stay and ride it out, and the fear network recalibrates. Medication options also have a strong evidence base, and the main clinical message is medication can reduce symptom intensity and frequency, but does not replace the learning that exposure provides. First-line medications typically include SSRIs such as sertraline or paroxetine, and SNRIs such as venlafaxine. It's important to set expectations that these take time, often several weeks, to reach full effect, and some people experience early side effects that require support and monitoring. Alternatives include TCAs such as imipramine, but side effects and tolerability need to be considered carefully, so shared decision making is essential. Benzodiazepines deserve special caution. They may reduce symptoms quickly, which can feel reinforcing, but risks include dependence, withdrawal, cognitive effects, and complications in the context of substance abuse disorders. If they're used, it's often short-term or adjunctive, and ideally paired with CBT to prevent the medication from becoming the only coping strategy. Now, I want to translate this into what I'd actually recommend in practice. Interoceptive exposure is central. That might include graded exercises like spinning in a chair to induce dizziness, climbing stairs to induce racing heart, paced hyperventilation to induce breathlessness sensations, or breath holding in controlled ways, always planned collaboratively and titrated to the client. Behavioral experiments are also key. If someone predicts, I will faint or I will die, we test those predictions systematically, not through reassurance, but through planned experiments that produce corrective learning. I also like an inhibitory learning focus. Instead of aiming only for symptom reduction, we aim for, I can tolerate this and it passes. Breathing and grounding skills can help, but I'm careful. If they become safety behaviors used to prevent panic rather than tolerate panic, they can maintain fear. So I frame skills as tools for regulation and recentering, not as rituals that guarantee safety. In terms of support, psychoeducation for partners or family can reduce reassurance traps and support exposure. Coordination with primary care may be needed for rule outs or medication management. Functioning supports like work or school accommodations can help graded re-engagement. And relapse prevention matters. Booster exposures, early warning signs, and a plan to respond with approach rather than avoidance. A simple decision guide is assess triggers, map the cycle, choose targets, exposure, cognition, skills as needed, and then measure change in frequency, avoidance, functioning, and self-efficacy. Finally, treatment should be evidence-based but also tailored. For adolescents, I'd more actively involve caregivers, integrate school supports, and keep exposures developmentally appropriate while reinforcing autonomy. For older adults, I'd more carefully screen medical contributors and adapt exposures for mobility or health limitations while still keeping approach-based learning central. For pregnancy or postpartum populations, medication decisions require careful risk-benefit discussion and coordination with OB care, while psychotherapy, especially CBT, often remains a strong option. If PTSD is comorbid, I take a trauma-informed approach to pacing. Sometimes we still start with panic-focused exposure if panic is preventing daily functioning, but we integrate trauma work thoughtfully so we don't overwhelm the system. If substance abuse is comorbid, I'd avoid benzodiazepines and target the pattern of substances functioning as safety behaviors while building alternative coping and approach behavior. Culture matters because symptom meaning matters. I want to understand the client's idioms of distress, what their body sensations mean in their family or community context. The DSM cultural formulation interview can support culturally responsive assessment. Exposures should fit the client's beliefs, language, and context. And we also need to access solutions, group CBT, telehealth, digital CBT, and interpreters when needed. My overall takeaway is match interventions to the client's triggers, avoidance goals, and cultural meaning while keeping exposure-based learning central. The two most useful questions clinically are, what are you afraid of that will happen, and what do you do to prevent it? Those guides guide the exposure plan. Thanks for watching. I hope you learned something today.